Good evening, everyone. Welcome to the online webinar sessions hosted on every Friday by the Department of Emergency Medicine, Yashoda Hospitals, Hyderabad. With the rising number of patients receiving pacemakers, CRT devices, and ventricular assist devices, ED physicians often face challenges with device-related presentations such as syncope, arrhythmias, inappropriate shocks, and heart failure exacerbations. And managing these cases requires clinical judgment, coordination with the cardiology team. In this webinar, we shall learn about practical bedside strategies, ECG clues, and safe emergency interventions. Joining us today is Dr. Bharat Vijay Purohit, Senior Interventional Cardiologist at Yashoda Hospitals, High Tech City. Welcome, sir.
Yeah. Hi, Dr. Manvita. I think it's a privilege to be on this show where so many doctors from critical care department are joining and really appreciate this novel work which you people are doing by conducting this webinar on every Friday evening for the benefit of all the ER doctors. So I think today we will be discussing a very interesting topic. So I am looking forward to it. Thank you for inviting me.
Yes, sir. Sir, can we know what will be the ECG findings or how will the patient with the pacemakers present with the ED? What are the basic symptoms they show?
See, basically, we need to understand. I think we were discussing about the what are the various devices a
Yes.
patient will have when he comes to the ER, and then we'll go to specific devices. The main three devices with which the patient comes to the ER is one is a pacemaker, second is an ICD, and third is called as CRT. The pacemaker is basically for bradyarrhythmias. When the
Okay.
patient's heart beating is so slow, the patient starts developing symptoms, either a syncope or giddiness or extreme fatigue, all those things. So, in that case, to improve his heart rate and to improve his symptoms, to save his life, we implant the patient a pacemaker. ICD is basically for tachyarrhythmias. So, for bradyarrhythmias, we have a pacemaker. For tachyarrhythmias, like especially ventricular tachyarrhythmias, like ventricular tachycardia, we implant ICD. Basically, it's a shock delivering device, just like what we have in our ER all the time, where we put the paddle or we have AEDs. So it is a miniaturized version. So where the leads are connected to the ventricle as well as the atrium, and they will sense that this patient has a ventricular tachycardia. And the algorithm is such that automatically it will detect, and we basically program it in such a way that initially it tries to convert a tachyarrhythmia by giving higher beats. Like if the VT is happening at the rate of 120, the device, if it is programmed, then it will give a ventricular beat at the rate of say 130 or 140. By that, it will try to suppress the abnormal electrical activity and terminate the VT. But if that doesn't happen, if the patient's life is becoming critical, the device straight away will give a shock. So it is basically to take care of the ventricular tachyarrhythmias and convert it into a sinus rhythm. Coming to the third device is a resynchronization, that is cardiac resynchronization therapy. It is neither for tachy nor for brady, but it is basically to convert an asynchronous beating of the ventricle, either the septal or lateral wall, they are not beating together, or the right ventricle and not left ventricle, they are not synchronously, they are not contracting, so that the effective cardiac output is less. Like take for example, a patient has got a left bundle branch block. So the electrical activity initially goes to the right side of the septum, or it goes to the right ventricle, and then through the myocardium it will start activating the lateral wall of the left ventricle. So because the myocardium is a very poor conductor, the QRS becomes very broad, and by the time the lateral wall starts contracting, the septum has already started relaxing. So instead of contraction like this, so when the septum starts contracting, the lateral wall is not doing anything. When the lateral wall starts contracting, the septum has already started going into diastole and it is relaxing. So the movement is like this. So instead of this type of movement, the movement has become like this. So effective cardiac output is less. So the resynchronization therapy, what we do is we keep a wire on the septum and we keep a wire on the lateral wall and we try to capture both together. So simultaneously, both the sides are depolarized and the contraction happens. So here we will have three wires, one in the atria to send three devices with which a patient will come to emergency room. And when the patient comes to the emergency room with these three kinds of devices, then we need to decide whether the devices are working appropriately or they are working inappropriately. So that we can identify by looking at the ECG and by understanding how the device has been implanted. Because nowadays there are so many different ways of implanting a pacemaker and all this thing. So the QRS varies. So unless and otherwise the ER doctor is aware that this device has been implanted in this particular way, by looking at the ECG, we may get confused. I'll give you a simple example. First, we are talking about the normal phenomenon. Then we will go to the abnormal. So I will tell you how. Suppose, let us now take, for example, pacemaker. In the pacemaker, there are various types of pacemaker we have. One is a lead pacemaker, another is a leadless pacemaker. So a patient comes and you suddenly see that the ECG is broad QRS LBB pattern, and you don't see then, because as a ER doctor we are used to seeing a pacemaker on the left clavicle or the below the right clavicle. So there should be a pocket, there should be a scar mark, there should be something there. But nowadays if the patient has a leadless pacemaker, you won't know it. And because these pacemakers are bipolar, they are not unipolar, so the pacing spikes you may see, you may not see, because the spikes are very narrow. If it is a unipolar, you will see a huge spike, a big spike followed by the QRS. But in a bipolar, you may not see that. So what you will see is, and if you are in a hurry, you will suddenly see that the patient is having a LBB pattern. And in our conventional method, we see that there is no bulge in the right or left side. So probably we think that patient baseline is LBBB. So unless and otherwise we do an X-ray or we specifically ask the patient, we will miss it. So in an X-ray, you can see a tiny capsule kind of a thing in the RV apex. So you know that this patient had a leadless pacemaker. So that is relatively uncommon right now, but it is something we should keep in our mind, that if a patient has come with a LBBB, don't forget that he might be having a leadless pacemaker. Coming to the conventional pacemaker, as I said, again, maybe two types. One is a single chamber where you have a lead only in the RV, or it may be a dual chamber where you will have a lead in the RA and as well as in the RV. So in a conventional pacemaker, the newer method of pacing is either called a conduction system pacing or a His bundle pacing. The conventional pacing is RV apical pacing. Now, what happened is, over a period of time when we had RV apical pacing, many a time this becomes an asynchronous pacing. Like the pacing is started from the RV apex and then going to other parts. So patients started developing LV dysfunction over a period. So as a cardiologist, we tried to simulate what exactly is our conventional method of depolarization. So here the QRS comes with the left side and comes to the right side. So what we did is we started pacing at a very higher level, that is near the His bundle. Or we started going from the RV type side of the septum by penetrating the septum and going towards the left side where the left bundle branch is there. So conventionally, we know from AV node, the fibers divide into left and right. So, and this patient has a complete heart block. So normally the conduction comes from the left side, goes to the right side of the septum and then goes all over left and right. So what we started doing is we started placing the lead by piercing the septum and going towards the left bundle. That is called left bundle branch pacing or conduction system pacing. So if somebody has a conduction system pacing, you may not see a conventional left bundle branch pattern in a pacemaker. So that is something which we must keep in our mind, that these patients will have a very narrow QRS. So just because somebody has a narrow QR doesn't mean that patient doesn't have a pacemaker. So in a regular ECG, what we will see, most of the time, if you see, the ECGs have these pacing spikes at the top of the ECG. So when you look at the top of the ECG, you will see a pacing spike like a vertical line at the top, you will see that, okay, these beats are probably pacing. If you are still not sure, if you very minutely see that the beginning of the QRS at the beginning of the P wave, you can see a very small, tiny spike kind of a thing, which if you are not careful, you will ignore it as an artifact, but otherwise you will be able to pick it up and you can identify that this patient has a conduction system pacing or a vis bundle pacing, and it is not a wide QRS like a conventional pacemaker. So a patient, how to identify the normal pacing rhythm? There should be a spike either in the QRS, P before P or before QRS, or you can see the same spike at the top of your ECG paper where you can see the spikes there. And you know that this patient has a pacemaker. And when you do an X-ray, you can easily identify that there is a pacemaker there. So sort of that, this is what you can identify. And when you do a 2D echo also, you can see the leads. When you put a 2D echo lead in this patient, you will see a lead in the RA and RV. So you know this patient has a pacemaker. So this is how, and when you look at the QRS, if it is a bundle branch, left bundle branch pattern, probably it's a apical pacing. If it is a narrow QRS, probably it's a CS pacing, conduction system pacing, or it could be a his bundle pacing. ICD, we don't have to worry because this is basically for tachyarrhythmia. So normally, if the patient won't have any conduction blockage, you will have a normal conventional ECG like any other person. If a patient has got a CRT, CRT, because the lead is on the left ventricle side, so you may see a right bundle branch pattern kind of a thing. So again, the pacing spike for the atria will come, and it is mandatory that all the beats in a CRT has to be captured. That means the target should be more than 97% of beats should be captured by the pacemaker. Then only you get the benefit of CRT. So if you see a ECG, definitely you will see that the QRS is narrow, or it may show a little bit of RBB pattern, and there will be a pacing spike before the QRS. So thereby you know that, okay, probably this patient has a CRT device. And in the history also, the patient will say, I had LV dysfunction and my doctor told me like this. And when you do a echo also, you can see all the leads there, and in X-ray also you can see. So this is how a patient who has a pacemaker or a CRT or a ICD, when he comes to the ER or any other problem and you see the ECG, we can identify what kind of pacemaker has been implanted and whether this pacemaker, if it is a normal functioning, this is how the normal pattern of ECG will be seen in such patients.
Okay, sir. And if there any, what are the steps of management if we see that pacemaker patient presents with syncope and brady? Is it same like all other patients?
Like, see, we are now confining ourselves to the devices, right? The
Yes.
two most important device I said is a pacemaker and an ICD. Now, if the patient has a syncope and he has come to the ER and we don't have a time, what exactly is happening? We just see that there is some we do a echo and we see that there is some leads there. So we don't know whether it was because of pacemaker or whether it was due to an ICD. So in that scenario, if the patient had a ICD, then definitely the ICD will give a shock.
Okay.
So you can identify that patient is getting a shock or not a shock. And if the patient has a pacemaker, you will definitely see spikes there. Now, despite a spike, if the patient is getting a syncope in a pacemaker, because we know pacemaker is because of bradycardia, and you see that the rate is, then you see whether the spike is actually leading to a capture or not.
Okay.
So that means there is a failure of capturing the ventricle. So even though there is a spike, but there is no capture. Or what you will see is that there are inappropriate spikes are present. That means the pacemaker is not at all sensing. It is just randomly giving spikes, but it is not at all sensing anything, whatever is there. So there may be two things. One is either there may be undersensing. That means it is not at all sensing the patient's intrinsic rhythms. That may be because of either the lead has become fractured or the threshold has gone high, like in patient who has got a heart attack, myocardial infarction, and where the patient's lead is there, if it is a scar area, it will not capture anything. Or the patient is having electrolyte imbalance like hyperkalemia and all those things, where the patient, even though there is a spike, but it is still not capturing. So in that case, what you will see is the patient will develop significant bradyarrhythmias. If the patient is oversensing, this is about undersensing. So in undersensing, what will happen is the pacemaker is not at all sensing anything. And because the pacemaker has a inbuilt fixture that if it doesn't sense anything, it feels that there is a asystole and it will start giving spikes. And because there is no lead contact, or because the lead has been fractured, insulation is not there, that spike is not leading to any capture because the entire energy is dissipating out. Because there is no contact, so where will it cause the depolarization of the myocardium? So this patient, they will, even though you can see a spike in the ECG, but there is no capture happening. So this is all about undersensing. Oversensing means if the patient has a myocardial twitch, like muscle twitch, or patient is having shivering, there's too much of muscle contractility is happening, then the patient will start sensing that as an atrial activity or a ventricular activity, and then it will inhibit itself from pacing anything. So even though the patient P wave has come or patient is going into asystole, but because of this shivering, the pacemaker is not at all giving any spikes. So even though the battery is all right, even though the insulation is all right, but still it is not happening. Now, what do we do about it? The best thing is put a magnet on it. The moment you put a magnet, the magnet will suppress everything and it will convert the entire pacemaker into no sensing here. It will only pace. It becomes a VOO mode. Only pacing, no sensing. So the immediately whole thing will disappear and the patient will start capturing. That will take care of your oversensing or undersensing part of the thing. So in a patient who has got a syncope, you must understand whether the syncope is due to pacemaker malfunction or it is due to any other cause of syncope. Like patient can have a vasovagal syncope, patient can have a neurological cause of syncope, tachycardia, which is giving rise to syncope. So just by looking at the ECG and by trying to put a magnet on this, you will be able to identify whether these are related to any pacemaker related issue or these are unrelated issues. I think there is one question somebody has raised, right? Somebody was.
I'll get to that, sir.
Yeah.
Uh, if in a patient with pacemaker dependent rhythm and we notice that there is a device failure, can we do temporary pacing in ED?
Oh, yes, of course, you can do because, as I said, the device failure means this patient's battery has been depleted or the patient is having a lead failure. That means the lead has either fractured or the lead has been dislodged. In that scenario, definitely you can go ahead and put a external pacemaker in them and then start pacing from the outside and then take the patient to the lab and then again reposition or put a temporary pacemaker in the lab itself. Of course, it can be done and it is a good option to do that.
Okay, sir. And how do we safely perform external defibrillator or cardioversion in patient with pacemakers?
That's a very valid question. Like if somebody comes with a patient has a pacemaker or because he had developed an MI or he has gone into shock or he has gone into cardiac arrest because of any other reason and we want to perform a CPR, there is no issue with CPR because we all know that the pacemaker is kept below the clavicle and our CPR hands are generally below the lower part of the sternum. So it is not at all going to interfere in any way to your conventional CPR, whatever you are going to do. Just follow your normal CPR technique, whatever you have been, whatever the pacemaker is there. So that takes care of that. Coming to defibrillation, if a patient has a pacemaker and you want to defibrillate, the conventional teaching is if you can put your pads antero-posterior, that is the best. That
Okay.
means the one pad on the left side chest and the other one is on the back side. Try to have at least 8 to 10 centimeter away from the pacemaker. But sometimes what happens is the pacemaker, it just it just drops down because the pacemaker is kept in the left clavicle or the right clavicle, and generally what we do is we put a stitch. I have seen in some people they have put absorbable sutures there. So absorbable sutures means after some time the pacemaker, that stitching which you have done, it gets absorbed, and the patient, because of its weight, starts dragging itself down, and because it has already been kept in a pocket, the pocket keep extending, going down and down towards the heart. So that becomes a little tricky issue. Otherwise, you can safely go ahead, and in case you are not sure and you have given a shock to this patient, don't worry. You can put the patient back on a magnet and a VO mode, and ask somebody to come and do the programming of this pacemaker after the defibrillation has been done. So try to put it anteroposterior. If possible, keep it 8 to 10 centimeter away from the pacemaker, and give your conventional joule, whatever you want to give for defibrillation. Nothing will happen.
Okay. And wheel focus or 2D echo, how is it useful in evaluating the patients with lead displacement or the patient going into cardiac tamponade?
See, basically, focus will not be able to tell you whether there is a lead displacement or not. If you are extremely you're very good in your pacemaker, then you will be able to trace the pacemaker lead. But generally, that is not a very good way of doing it. The best way is to check in the X-ray. You can go do it in the fluoro, and you can see whether the lead has been displaced or not. Yes, for tamponade, definitely it's a good option. And if the tamponade has happened because of the pacemaker lead, so what happens is, sometimes patient who has got an MI, and there is a scar tissue, or the myocardium become thin, and you have put a screwing lead there, and you find that subsequently the lead is perforated and gone in. So what will happen is, because the lead has gone into the pericardium, the thresholds will go away. So you will have spikes, or you will have very, very high threshold for capturing. So in that scenario, patient has a effusion and the thresholds have gone very high. So you know that this probably the lead has perforated and gone beyond it. So that is how generally we suspect and treat them. So if there is a tamponade, we follow the regular procedure of doing a drainage from the subgifoid area, remove the fluid, and take the patient for a temporary pacemaker, because if it is a dependent patient, we need to reposition it. So try to avoid in the inferior part of the RV, because they are very thin. Try to put your lead in more in the septal region, either in the apical septum or mid septum, whichever is a thicker part of the septum, so that even if there is a perforation, nothing will happen. Because if you are perforating the septum, what will happen? There will be left to right shunt. Patient is not going to die there, so nothing will happen. So most lead perforations happen when you have put it in the inferior part. So try to be, when you are positioning, so that's basically for the cardiologist, obviously. Try to put the lead in the apical septum, so that it doesn't cause any perforation. But yes, if there is a perforation due to lead, the thresholds will be very, very high, and you will not see any capture in the ECGs. And when you do a focus, you can clearly see that there is a fluid around it, and that way you can suspect and treat this patient.
Okay, sir. And how to identify MI in pacemaker patient with chest pain?
Oh, that's a very, very, very. Suppose a patient has come with a chest pain, and you have taken the patient to the for the ECG, and suddenly you find there is a LBBB. So identifying a MI in a chest pain patient who has got a baseline LBBB is similar to identifying an MI in a patient who has got a baseline LBBB ECG pattern. We generally follow a criteria called
That
Garbosa's criteria, and nowadays we are following the modified criteria. So what generally we do is, we check if the QRS is upright or QRS is downwards. So concordant ST elevation or ST depression more than 1 millimeter. If the discordant elevation should be more than 5 millimeter. And nowadays, what we are doing is, we are checking the R to discordant ST elevation or depression ratio. If generally we go by 5 millimeter ST elevation in the discordant lead, like take for example, you have a V1. In V1, it's an LBB pattern, means QRS is predominantly downwards, and you have a ST elevation which is more than 5 millimeters. So we measure the length of the QRS, and we also measure the length of the ST elevation. So ST by T ratio, what is the QRS? ST by S. whatever is the duration, if the ST elevation is, say, take for example 5 millimeter, and the S wave is, say, take for example 15 millimeter. So in that case, the ratio becomes 5 by 15, so 0.33. So anything more than 0.25 is considered as a sign or that it is probably a significant ST discordant ST elevation. So we generally follow these criteria, and if they fulfill all this criteria, definitely. Or if the patients take for example V6 generally in a LBB pattern, you will have a ST depression and T inversion. But if you are seeing there is a ST elevation in that, so that means it is a concordant ST elevation. So that's a very, very positive sign that patient is having an MI. Inferior leads in a patient who has got a LBBB, inferior lead changes are not at all affected. So if a patient has got an inferior MI, you can clearly see in 2-3 ABF, because that is not affected by this LBB pattern. So that way you can safely identify inferior by a conventional MI criteria. But if it is an interval MI, then you need to follow this. Because when you do a 2D echo, there will be septal paradoxical movement, which many times gets confused that this is related to this to MI or not. And third thing is, if a patient has got an MI and he is presented with a LBBB, and you are not sure whether he's pacing or not pacing in emergency, generally an acute LBBB are very sick patients, because it's a very extensive MI. Because LBBB is not like a bundle; it's like a big arborizing fan kind of a tract. So if such a big tract gets affected completely, means it's a huge myocardium has been damaged, and patient will be very sick. He will be in cardiogenic shock, pulmonary edema, and all this thing. So if you follow this Garbosa's criteria, definitely we will be able to identify very clearly whether the patient has got a MI in presence of paced rhythm or not.
Okay, sir. And what will be the precautions if we want to do MRI for the patients with the device? And if we know what type of device he's having, and or if we don't know what device he's with?
Right. First and foremost is on the moment patient comes, we are not sure because the patient has a headache or he has got a CVA kind of a thing, and you don't have time to identify what needs to be done, right? See, generally it is said that you should go ahead with an MRI in an MRI compatible pacemaker. But in an emergency, if you are not sure whether it is MRI compatible or not, there was a study done in Bombay where they did MRI even in MRI non-compatible pacemakers also, and they found that nothing happened to these patients. So you can up to 1.5 Tesla MRI you can still do if you are not sure and you have absolutely no way to find out whether this patient is MRI compatible or not, you are in a real emergency where you have no other option, then after explaining everything to the patient, you can still go ahead and do it, and hope that nothing will happen, because the study said nothing happened. So that is something which gives us confidence that even with non-MRI compatible also we can go ahead and do it. Now, coming to the MRI compatible pacemakers, most of the time the hospitals like our hospital, we always have all the machines which actually do the programming in our hospital. So our technicians are quite familiar with them. So we generally give a call to our cath lab and ask the technician to come with the machine, which pacemaker it is. We bring the same machine and we convert the pacemaker into an asynchronous mode that is called VOO mode, where there is no sensing, because we know that magnet will always interfere with the sensing. So if you remove the sensing part, the patient will keep getting the pacing only. And because they are MRI compatible, nothing will happen. So you are eliminating the sensing part because of the magnetic field. And thereby nothing happens. And once the patient is finished with MRI, you can change it back to the conventional mode. So change the pacemaker into a asynchronous mode that is called a VOO, where there is only pacing, no sensing. And if you are still, and how to identify the pacemaker, you can do an X-ray, and many a times in X-ray you will be able to identify which company pacemaker it is, because it will be written there. And you will be able to, if you have taken a very high resolution pacemaker, you will be able to see in the leads or in the pacemaker, the markers will be there, and by that you can identify which company it is, and you can call the same company and the same machine can come and do the programming for that. Because if the patient doesn't bring anything and you are still worrying what kind of pacemaker it is, take an X-ray, look at the marker, what marker has been written there, and there will be some subtle marker like Boston, St. Jude Medical will have SJM, Boston Scientific will BSc. So like that, those markers will be there, and with that you can identify what pacemaker it is. Get that machine, program it to asynchronous mode, take the patient to the MRI, finish the MRI, bring the patient back, change him back again to the whatever the programming was done beforehand, and then send the patient back. If it is a absolutely you have no clue what it is, whether MRI compatible or non-compatible, explain the necessity and the risk involved, and go ahead and do. Most likely you will get away with it, because if it is a 1.5 Tesla, nothing will happen.
Okay, sir, can you share with us any personal experience you had challenging treating these patients with pacing? Who has come to our ED with Brady syncope and is really bad at presentation? Any personal experience, sir?
I never had anybody with Brady. Brady only came with a few patients where the leads were, the battery was end of life. So what we did is we just took the patient for a temporary and went ahead with. One interesting patient we had was, the patient was on a pacemaker, but he came with extremely high heart rate. The
Okay.
heart rate was, I think, almost 170 or 180. Generally, in pacemaker, the upper tracking rate, maximum tracking rate is kept around 150 or 160. So the pacemaker cannot pace beyond that rate. But if the rate is very high, then we need to suspect why this is. Is it an intrinsic rhythm or not? So what generally happens in this is called a very classical example of pacemaker mediated tachycardia. So where what happens is, when the patient has it happens only in dual chamber pacemaker basically. So there is a atrial contractility, that means the atria had been paced, and based on that the impulse comes down to the ventricle. So the ventricle again, if it is not coming down because of CHP, the ventricle also gets a paced rhythm. So the moment based on the atrial sensing, when the ventricle is paced, if there is a tract either through the AV node or there is a bypass tract outside, if there is a retrograde VA conduction, so what will happen is from ventricle it will conduct back into the atria again. So atria gets spaced again. And the moment atria gets spaced, immediately again there will be another impulse coming back into the ventricle. So it becomes like a re-entrant kind of a tachycardia. And the patient suddenly goes into severe tachy. We call it as a pacemaker mediated tachycardia, which is mainly because of the VA conduction in a dual chamber. So this patient came with a very high rate. We were thinking whether it is a VT or something like this. So what I did is immediately we put a magnet on this. The moment you put a magnet, as I told you, there is no more atrial activity. It is just a simple VOO mode. So you cannot go for any sensing here. So even if there is a retrograde conduction, there won't be any sensing. And if there is no sensing, there won't be any more pacing. So it is the immediately the tachycardia converted into the sinus rhythm. So we were thinking of giving a shock. We were thinking of doing something, but just a simple magnet was able to terminate the tachycardia, and we were able to avoid giving any DC shock to this patient. So that is something which we all should be very, very careful. If a patient with a pacemaker comes with an extreme tachy, and if you see that the hemodynamics are little stable, because in a VT generally we expect the BP to go down, but the hemodynamics are stable, so don't panic. Think that it could be pacemaker mediated tachycardia, and you can just put a magnet and convert it. Another patient who came with, even though the patient was on a pacemaker, still what we saw is that there was a 2:1 or a Wenkebeck kind of a conduction, and we were worried. Why did this patient, even though he is a pacemaker, why there is a Wenkebeck phenomenon? Now this is not abnormal. This is a safety mechanism to prevent the heart from beating faster. So if the atrial activity is fast, many a times the pacemaker will not conduct, because the pacemaker, the atrial rhythm, when the moment there is atrial activity, it goes down, it falls in a period called post ventricular atrial refractory period, or PVARP. And the moment that happens, there won't be any sensing, there won't be any pacing. So it will appear as if there is a P wave followed by gradual QRS, and there will be a drop beat. So this is a very classical example of 2:2 anchor back phenomenon, which is very natural and which is physiological. So we need not worry that this patient is having a pacemaker failure. We just have to readjust the patient's PVARP, and the things will automatically come to normal. There was another patient where we found that continuously the patient was actually was pacing pretty high. So what has happened is, in this patient, there was oversensing in this patient, and continuously the patient was going into syncope. So when we checked, what we found is that the atrial pacing was very high. The thresholds were pretty high. So what happened is, when your thresholds are high, the pacemaker gives a very high voltage. And if your ventricular sensing is kept low, so suppose the pacemaker is pacing the atria at say 4 volt. So pacemaker has given a 4 volt of energy, whereas the ventricle has a sensing of say 1 volt. So what will happen is, immediately it will sense that there is some activities has happened. So it will inhibit. It will say, okay, such a 4 volt activity has come, so that means it's a QRS. Let me not pace anything. And because there was a complete heart block, the patient was going to syncope again and again. So we had to reduce the threshold and we had to reposition it. Till that time, what we did is we converted the patient from DDDR to VVIR. And then there was continuous pacing into the ventricle, and we suppressed the atrial activity. And after that, after we brought the patient back and revised the atrial lead and we repositioned it, and then the DDR was working fine. So these are some of the interesting cases which I had seen, where the patient was having a syncope, and this syncope was not because of anything, it was because of oversensing, because of the very high atrial thresholds, which the ventricle was sensing as a QRS complex, and it was not at all pacing. So, and then, as I said, there was an interesting patient who had got a pacemaker mediated tachycardia, which we just converted by putting a magnet on that. And there was a patient who was asymptomatic, but his heart rate was becoming low. And then when we took a ECG, we were finding this Wenkebeck phenomenon. So that again was a physiological, nothing to worry. But many a times you have to be careful, and you should not miss on all these phenomena just by thinking that are physiological. You should be careful and talk to do a proper analysis of the pacemaker interrogation should be done by the device, and see what are the refractory periods which have been kept, and then accordingly you plan it.
Sir, if the symptoms are because of the electrolyte imbalances, mainly hyperkalemia, by treating this, can we completely reverse the symptoms, sir?
Of course. See, basically, if you have electrolyte imbalance, the thresholds will go up and the patient will not pace. So the moment you change the electrolyte back to the normal, automatically the pacing will come back. Nothing
Okay.
will happen.
So you have really cleared our doubts mainly regarding the CPR and the cardio version, what we are very scared of, and also regarding the MRIs. Usually we think that we don't know how to do the CPR or give the external defibrillation in patients with pacemaker. We'll be very scared to do that.
No, no, nothing to worry. Because the pacemaker is quite far away, so you need not worry anything about it. But for defibrillation, I will always prefer go with the
Anterior.
biphagic one, and then put it anteroposterior if possible.
Yes, sir. Yes, sir. Yeah, thank you so much for clearing the doubts on all the cardiac implantable devices and how to approach for us from emergency point of view.
Thank you. Thank you.
Thank you so much,
Take
sir.
care. Take care.
Yes, sir.